So the answer would be yes. You can use those in diabetes. I know they're not technically approved by Health Canada or things like that, but it's in the guidelines. Everybody uses them. So I feel in that case, it's reasonable to use. I've used them a bunch of times in my patients who have neuropathy. So yes, mostly anticholinergic side effects, dry eyes, dry mouth. Usually these people are kind of elderly too, so you really have, I start on a very, very low dose. Like with amitriptyline, I'll start with 5 or 10 milligrams, which is a really low dose, and just slowly increase. Yeah, there's bladder issue. Like with a lot of people, dry eyes, dry mouth, urinary retention, those are all major issues to seniors. But a lot of times they have a lot of bad neuropathy too, especially it interferes with your sleep. And so a benefit is that amitriptyline, nortriptyline, those kind of medications also tend to make you sleepy so that they can get some sleep. But it's kind of like a benefit versus risk kind of thing, because there are side effects. So, and a lot of patients, when they think of a cure, they're thinking like 100% pain reduction, and that's just not realistic. If you can get 30% pain reduction, that would be a success. So it'd be important just to let them know that, hey, there are some medications we can try for this, but you're looking at a 30% reduction at best, and there are a lot of side effects. Try to find the lowest dose that causes the most pain relief benefit with the least amount of side effects. Does that answer your question, Casey? Yes, exactly. There's very no chance of like zero pain. So just make sure your patients have the right expectation. Yeah. Okay, Irene, would you elaborate on alcohol and hypoglycemia? Yes, that's basically it. So when people are having alcohol, it's exhausting. Your liver is busy dealing with the alcohol and not producing sugar. So your liver is a storage depot for glycogen, which is what can be converted into glucose quickly. And so the liver stores about 75 grams of glycogen, which is like half a loaf of bread roughly. And the liver can, through glycogenolysis, break that down in sugar. But it requires this enzyme, I think it's like NADH or something like that. And when you have alcohol in the body, your liver uses all that enzyme to break down alcohol and not glycogen. So if you have a low if your patient is having a low during alcohol, it can get more severe because the liver can't compensate. And things like glucagon don't really work either, because glucagon tells the liver to produce more sugar. But the liver is saying, hey, I'm busy dealing with the alcohol, go talk to someone else, I'm busy. And so, and so then, then it doesn't work as well. Does that answer your question, Irene? Perfect, good. Yeah. Welcome, Penny. This is just a casual session to ask questions. Some people are just here listening, and yeah, go ahead. I saw yourself on mute. Which diabetes are contributed with cirrhosis or severe alcohol use? Metformin comes to mind right away because it works on the liver. That's a good question. There are some medications that, so usually medications, if they don't go for the kidney, they go for the liver. So I don't have a comprehensive list, but usually if they're not, if you look on that diagram, there's that kidney diagram that everyone hates and everyone asks questions about. Here, give me 1 second. Where is it? Here. So generally, if they're not affected by the kidney much, like repaglinide, then usually they go for the liver. So for the exam, you'd probably just need to know metformin. But you'd have to look at the individual product monographs for each individual one. And let me show you how to do that because you'll probably run into this eventually anyway. So you just go drug product database, and this should bring you to Health Canada. I should probably move this to somewhere over here. And then you just go search the drug product database. Go to marketed if it's already marketed, and you can just put the name here, glucagon. Click on this, click on this. And then you can just Google hepatic. So yeah, so glucanorm, because it's not really, as you can see here, it doesn't go through the kidneys much. It mostly goes through the liver. So, but it doesn't have any special recommendations for it. So I'll just know about metformin. Yeah, absolutely. And feel free to do so. Like, there's sometimes there's the answer for the exam and the answer in real life. So feel free to ask about either one. Like I just work in primary care, so I don't have any expertise in pediatrics or geriatrics or pregnancy, but or emergency. Some people at the noon session were asking about like DKA and HHS, and I'm like, oh, I'll just page the emergency doctor in that case. But yeah, feel free to ask any questions you want. Okay, so peel glitazone and uh, that kind of class, the TZDs. So what happened was that with Avandia, there was a time where they thought Avandia actually increased myocardial infarctions. And so then when you have, and pioglitazone and rosiglitazone are in the same class. So at that time, they were thinking, oh, is this a class effect? Should we be putting people on pioglitazone if rosiglitazone is so terrible? There was a time where you had to, in order to put someone on rosiglitazone, you had to like fill this form, like, I understand that this is super risky, and the physician is aware that this is a huge risk that this might increase my chance of heart attacks and stuff like that. So because of all the bad attention that rosiglitazone got, pioglitazone kind of got like the collateral damage. And so that's kind of why it's not as popular. That's part of why it's not as popular anymore. The other problem is that pioglitazone causes weight gain, which we don't want. We don't want in people with diabetes. Pioglitazone can also cause like bladder cancer, and it is also associated with these weird, they call it carrots, weird atypical fractures where it's like almost like a carrot stick fracture. It looks like, you know how when you break a carrot, there's like this little lump here and a little hole here. It's associated with those kind of bone fractures. So if you take all of that together, like who would I prescribe that for? So I'd have to prescribe it for someone who's not a woman, who doesn't have bladder cancer, who's not overweight, who's okay with gaining some weight, who doesn't have heart failure. So that list of patients who I can prescribe it to becomes very small. And so that's why it's rarely used much anymore. Like, it's probably not a bad drug, but oh my God, okay. It's probably not like a bad drug, but given that there are better drugs now, like it used to be like it'd be metformin, glyburide, and then you go to insulin. But now there's like tons and tons of options. So that's kind of why it's not as popular anymore. I think it's still a reasonable medication, but definitely that whole class has just fallen out of favor. Yeah, does that answer your question, Casey? Okay, perfect. So yeah, to all the new people, feel free to just ask questions. This is a very casual session. Feel free to unmute yourself and ask a question or just put it in the chat box. Is Lorraine here? Oh, I'm in the middle of answering your question. You are here. I'm just here answering your question right now.
Okay, perfect. Thank you.
Yeah. So does this make sense? This I couldn't download your picture because it was too big for my system. Let me see if I can actually find sure, I'll get to you in 1 sec, Marley. But Lorraine, did this answer your question fully?
Yes, it does.
Okay.
Yeah.
And also for this question about the percentages, generally once they get high enough, I'll just start doing a percentage. Like if, like I've got this patient who's on like 300 units. I think it's Toujeo, but it could be Tresiba, but like going up by 1 would be pointless. So in those cases, you know, I would go up by like 30 units a day because he's on such a huge amount of insulin.
Okay.
Perfect. Okay. Okay, Marley, what questions do you? I think I have some of your questions here, but do you have any additional questions?
No, I think it was just the travel. I do struggle with that one. The time zones and changes. And then just differentiating the autonomic complications. It was one of the questions on the essentials binder that I got wrong.
Okay, so I feel that decreased sensation would be an autonomic complication.
Well, I thought it was.
Okay, which question is that? Can you?
I gotta go get it. Hold on a second.
Okay,
Yeah.
sure. Time zone questions. Okay, I've got some things with time zone. I did. Okay. Currently, I don't. Okay, do you mind going over the mechanisms behind? Okay. So, okay, so the.
Okay.
Okay, I'll get to you in a sec, Lorraine.
Yeah, yeah.
This essential binders is so heavy. So was it was a question on autonomy? Okay, while you're looking that up, Marley, I'll just answer Lorraine's question. So I think the short answer is that no one knows exactly. How we think it happens is that SGLT2 inhibitors actually increase glucagon secretion. And glucagon secretion is a counterregulatory hormone. And so the problem, and then high sugar stimulates insulin. So the theory is that, okay, you've got this SGLT2 inhibitor that's getting rid of sugar. So there's not high insulin secreting, there's not high sugars stimulating insulin secretion. And then on the flip side, you have SGLT2 inhibitors increasing glucagon. So what happens is that they think that because you've got a low insulin level with a high counter-regulatory hormone level, that triggers DKA, and then that's why there's DKA even though the sugars are okay, because the extra sugar is being peed out, so there's no high sugar stimulating insulin release. That's how I understand it. But you can ask specialists and they might give you a couple different answers, but that's how generally it's understood at this current moment. Yeah, does that make sense, Lorraine?
So there's more glucagon, which creates more sugar, but
It counters insulin, which there's a low supply of already because there's no high sugar. The sugar's on high, so it's not stimulating insulin release.
Right, but the glucagon is still being released. Is that what you're saying?
Yeah, SGLT2 inhibitors actually they increase glucagon secretion. Okay. So that counters the low insulin. And then they think the combination of low insulin and high counter-regulatory hormones triggers DKA.
Okay, all right, yeah. That makes sense.
Yeah, that's the current theory. That might change, and the specialists are arguing exactly how it happens, but that's my understanding currently.
Okay.
That won't show up on the exam because no one agrees on how it works right now anyway.
Okay.
You just need to know it exists.
Okay, perfect.
Okay. Marlee, did you find that question?
No, I can't find it now.
Oh, no.
I know it's in here.
Does anyone else know which questions in the essentials that they're talking
weird. Like, am I missing a page here or something? Just a second. And then the travel stuff was kind of the other one that, like, is there the time zones? And I find that all very confusing.
Okay, so you don't.
I found it. Sorry, Esmond. Which of the following is not? It's question 17.
17. Okay.
Is not a diabetes complication involving the autonomic nervous system.
Okay, I think I know what it means. Okay. So it's just right here. I don't know if you can see that. So, okay, so what I think it is all those other ones are kind of automatic responses. Like, you don't control your sweating, you don't control your stomach. Well, I guess you don't control your sensation too, but.
Yeah, that's why it doesn't make sense. Peripheral neuropathy is not.
Yeah. I'm not sure why that answer is. I suppose sensation requires like some thinking about it, but other ones don't. That's how I would see it. You're right. I think this is a questionable question. Yeah.
Okay. Okay. Well, it's there. If they repeat it, I'll get it right. And then the time zones kind of like.
Sure. So you don't have to memorize the time zones for the exam. Basically, you just need to know that as you go east, you lose time, and as you go west, you gain time. So actually, let me see if I can find some. This is a great resource if it shows up. You might need a subscription. Nope, that's not it. Here we go. Where is it? Nope. Okay. Okay. So basically, so if you're losing time, you want to decrease the insulin. And if you're No, wait, sorry. Yeah, if you're losing time, you want to decrease the insulin. So as you go west, you're losing time. So you want to
No, as you go east, you lose time, you said.
let me
East.
let me look that up before I get myself
Yeah,
confused.
I think it's east.
Yeah.
Yes, that's right. That's right. So when you lose time, you want to decrease the amount of insulin that you give the patient because their day is shorter. And if they're gaining time, then you don't generally increase the basal insulin. Like if they have like a 40-hour day, they'll probably have an extra meal. Then you just give them an extra bolus. And if they're not on bolus, then you probably wouldn't adjust anything. And generally, just as Casey said, generally, if it's 4 hours or more, you don't. If it's less than 4 hours, generally you don't change it. And yeah, the biggest
You
concern
mean
is
less than a 4-hour time change? Like if they went from Calgary to Toronto, you wouldn't make a change?
no, generally not in real life. Usually, if it's more than 4 hours, then I would change it. Uh, and like in real life, nowadays, if I have a frequent traveler, I just switch them to Tresiba, and that.
Oh, yeah, totally. But for the exam,
Mhm.
if Tresiba isn't on the, if Tresiba isn't on it.
Yeah. So yeah, as you lose time, you want to decrease your insulin, and if you gain time, you generally don't increase the insulin. You just give them an extra bolus with their meal, and that's
Okay.
probably all you need to know for the exam. I know
Okay.
it seems more I know, like in real life, I had this patient travel to like New Zealand, and she traveled to Egypt, and then she traveled to like Africa, and trying to do the time zone things were just insane.
Tresiba.
Yeah, exactly. It was a while ago, so Tresiba wasn't out yet. So I was like, oh my God.
Okay. Okay, those are my questions.
Wonderful.
Thanks.
No worries. Yeah. And if they can afford it, yeah. In Alberta, it is covered by Blue Cross. So they're actually taking Lantus off the formulary, interestingly enough. So, but yeah, Tresiba is covered by Alberta Blue Cross. But yeah, it is more expensive than other insulins because it's newer. Do we need to memorize the names of the studies? I don't think you need to memorize the names of it, but like maybe just the DCCT because it was a landmark trial. You may need to know that, okay, the UK PDS studied people with type 2 diabetes. Sometimes they have a question on how much did the intensive arm improve, like retinopathy or nephropathy and stuff like that. Same
You
thing.
happen to know what that is? Because I got that question wrong on my essentials test. So the UK PDS is type 2 and the DC, no. I thought UK PDS was type 1.
No, UK PDS is type 2. And then the DCCT and EDIC is type 1.
Okay.
Yeah. Let me see here. Oh, the names that looked at prevention to type 1 diabetes. No, like for the exam, you just need to know that we don't have enough research to show that anything prevents type 1 diabetes. Yeah, sorry about that. I misread your question, Lorraine. Did I get everyone's questions? Yeah.
So what's the big takeaway from the UK PDS? Is that the one where they had the two groups, that one group had intensive therapy, intensive management, the other didn't? In the end, they had the same A1C, but the intensive management group had staved off chronic complications. Is that study?
Yep. That's called the legacy effect.
Right. Yeah.
So, yeah. So basically, for the UK, so the UK PDS in total is a 20-year trial. So that's why it was such a landmark trial. So for the first 10 years, there was a placebo group that got usual care, And then there's an intensive group that got intensive insulin therapy, glucose lowering, et cetera, et cetera. So the average A1C in the placebo group was 9, and the average A1C in the treatment group was 7. After 10 years, everyone was discharged, kicked out of the study. The people who had intensive care, their A1C slowly went up to about 7.9. And then the placebo group, after 10 years, they found that people in the treatment group did better. They had less nephropathy, less heart disease, less microvascular disease. And so after 10 years, everyone was kicked out. The A1C of the people in intensive group therapy without their educators and without the intensive therapy, it went up to 7.9. And then the placebo group got wind that, hey, all these people had these benefits, and so their A1C went down to 8.1. So 10 years after that, so this is 20 years later, they found that the people who, even though their A1C was very similar, 7.9 and 8.1, they found that the people who in intensive arm therapy had less microvascular and macrovascular complications than the placebo arm, even though their A1C was basically almost the same, 7.9 versus 8.1. So then they dubbed that the legacy effect, that, you know, early control matters. Yeah. Okay. Anyone else have any questions? Okay, no worries, Tara. So, so it's based on, they use this formula, but basically you're being marked on a curve. And so you do need to pass all the competencies, like in the, if you look at exam handbook, you know, you'll see that there's like the pathophysiology competency, the nutrition competency, et cetera, et cetera. Yep. And so, yeah, you do need to pass all those different competencies. Then you're kind of rated on a curve. And if you are high enough on the curve, then you pass. There's no, you don't get a mark or anything like that. It's simply a pass-fail system. And yeah. Hey, did they tell you when you'll get your results by any chance? I'm assuming because it's done on computer, you'll get your results faster.
I don't know. I didn't hear.
No?
I haven't heard. No.
Okay. I was hoping you'd get your results faster. Okay. Oh, December. Okay, that's good. Okay, Casey. Oh yeah. I've got, like, based on refunds, I've got like 95, 96% pass rate. So I feel you have a pretty, if you do well, especially if you can do well on my exams, then you've got a really good chance of passing. So I do, and I talked about this at the noon group, but I'll talk about it again. So the two most important things, I think, the two things that I found in people who failed the exam are, one, they ran out of time, or two, they went back and changed a whole bunch of answers. So that's kind of why I emphasize time on my practice exams. Try to make sure that you keep an eye on the clock. People who run out of time generally don't pass. And so if you find a question that you can't answer, just skip it. Don't stick around a long time on it. Because remember, there's a couple of these things called pilot questions. And these are questions that they're just testing out to see if enough people get it right. They're not actually real questions. Because what the CDECB will do is they'll have a question, the answer will be A, but if everyone picks D, then they know that, okay, this question was no good. And so if you waste, even if you spend a lot of time on them, it's not worth any marks. So even if you spend like 20, 30 minutes on it and got it right, it's not worth anything. So it's really important that through the exam, if you have a question you don't know, just skip it and go on and keep on going. Then afterwards, answer all those difficult questions. And when you're rereading the exam, try not to change your answers too much. Usually your gut feel for your first answer is actually the correct answer. Most of my students who've not passed changed a whole bunch of their answers. Oh, I've got a lot of chat here. And so those two things are important. One is to keep an eye on the time, and two, try not to change your first answers too much. Okay. Hey, Gloriana. In the ACEs, they talk about using. So that kind of depends on the cardiologist. If it's for if it's for secondary, like if they've had a heart attack before or any cardiovascular event, stroke, etc., then definitely they would use double antiplatelet therapy. If it's for primary prevention, like they haven't had a heart attack before, that's kind of more up to the cardiologist, and there's another set of guidelines for those which you would have to look into. But for the exam, if it's secondary, then definitely yes. If not, then that's kind of up to the cardiologist. I doubt that they'd ask that on the exam. Yeah, does that answer your question, Gloriana? Got it. Okay, perfect. Okay, I just want to make sure. Call to verify. Okay, 6 weeks. That's good. Do well. 90%. What's the passing score? So Rita just messaged me. So there is no passing score. It's based on a curve, and you do have to pass every competency. And so the passing score is always changing. So it's kind of where you place on that curve, but you do need to pass every competency to pass the exam. Yeah. Okay. Yeah, so I'll be here till 5:30. If you do have questions, please feel free to ask me. Otherwise, I'm just answering questions here and posting them online so that other people can see. Yeah, and
so Esmond, if I have more questions as I'm going along, I can. Will you just? Do I keep this open and you will just post them here until 5:30 or what?
You could just email me. If you want to interact with me, you can just unmute yourself and ask me. Yeah, whatever works better for you.
Okay, thanks.
Yeah. Okay, hi Jen. With it being long, does everyone have the same exam? Probably not. Like even when in the paper version, which I've written, there's actually 5 different versions of the exam. So that way people can't say, hey, the question to 2 is B and stuff like that. I'll get to your question just a sec, AC. So like computer generated random questions. So no, these questions are created by the CDECB and they've been verified through pilot questions. So pilot questions are questions that have shown up in previous exams that are not worth marks, and they've found that, okay, most of the people got the right answer. So I would assume that they would do the same thing for the online one. This is the first time they've done it, and first time that they've done it. So I would assume everyone would have, all the exams would be different, yeah. Okay, I hope that answers your question, Jen. With respect to the diet section, yes, I believe so. So that is over here. So this is probably the one that you'll use mostly. This is the most up-to-date version. There is an older version. Let me see here. Here. Yeah, this one's pretty old, but it has more food groups like the notorious ginger snaps and popsicles and stuff like that. So for the ginger snaps and popsicles, I'd take it from here. And then for everything else, let me just close this. For everything else, I would just get it from here. I noticed that in type 2 children, you mentioned that those was, yeah, I know. Like a lot of the problem I have with the exam is that a lot of this stuff I would just look up in real life. I wouldn't memorize this stuff in real life. So I feel that that is sometimes not a good predictor of a good CDE kind of like, but they're the guys that make the test, not me. So you can complain about it afterwards in the after survey, but complaining about it now won't help. Okay, notice type 2. Yeah, it's a hoop. It's totally exactly what it is. A hoop that we jump through. That totally feels like it. Okay, then type 2 DM children, they mentioned that those with AIDS, you start insulin. Okay. That is a good question, Gloriana. I don't think so. Like, I don't have any experience in pediatrics, as I mentioned at the start. I would assume that it's just 9 that you would do it. Let me just take a double look here. That's way, yeah. The children's chapter is way down here. Yeah, I would just use 9%, just exactly as the guidelines state. Yeah, I wouldn't use that one point. I wouldn't use that adult stuff in the kids. It's not always the same. Okay, and is metformin the only approved oral? I would say yes, actually. I suppose insulin is also, well, yeah, maybe. It could be just that 1.5 makes it 9. So that would, maybe that's where that 1.5 to 9 comes from. Let me just double check on the metformin part. I believe metformin's only one. Yeah, here we go. Okay. So there is some evidence for glimperamide as well, right here. To be honest, I'm not sure even if metformin is indicated in children, because sometimes what the guidelines recommend and what the official approval from Health Canada is different. So let me explain how that works quickly. Health Canada is a government organization that drug companies go to for certain indications, approval for uses in medications. For things like metformin, but it costs like millions of dollars and it's a ton of work to do it. For medications like metformin, they've gone what's called generic. So the original makers of metformin, I don't know if they're still around even, but they would be the ones who would submit to Health Canada the paperwork to get this official indication. So sometimes if there's no one to submit the paperwork, they don't have medications in the eyes of Health Canada, don't have the indication to be used in certain treatment populations. But in real life practice, probably metformin and sometimes glimperamide is used all the time. So be careful about your wording, Gloriana, on the exam, because if they said, oh, is metformin Health Canada approved for type 2 DM, it might not be. I'll actually look that up right now. So you could say it's recommended by the guidelines, but if it says, oh, Health Canada approved, you might run into problems with that. Let me just take a quick look. So I want to show, let me just see here. And let me just look at this and I'll take a look at the new message. So this is the Health Canada drug database. You just go drug product database, Google this, and this should be Health Canada. Then you go here, you type in your active ingredient. Make sure you put marketed as well, or else it'll show nothing. Let's see what the monograph shows. Is my internet working? What the heck? Okay, let me try this a different way. Okay, let's see if this is indicated in children. Indications. Okay, it doesn't say contraindicated with kids or anything like that. During pregnancy is contraindicated. So I guess it would be okay. I hope that answers your question, Gloriana. Okay, perfect. Yes, that's 100% correct, Casey. If they're symptomatic, they would definitely be started on insulin. Yeah, so yeah, this is totally like a corner case exam kind of question. In real life, if they're symptomatic, you just put them on insulin right away. Okay. Yeah, so if anybody has any other questions, feel free to just chat it into the chat box or unmute yourself. Otherwise, I'm just going to put a written answer from Marlise's questions. And yeah.
Thanks, Esmond.
No problem. What is the actual, I believe it's 1,000 to 1,500. Let's find out. It's in the nutrition section, which is 64. It should be right. I believe glucagon has other mechanisms of action to increase glucose, but in terms like when I was talking, if you were here for the alcohol question, that is how alcohol blocks the effect of glucagon. It's one of the major modes of how glucagon works. So let me just, actually here, let me just finish one question. Sorry about that. Here it is. Who asked that? Penny. So it's 1,000 to 1,500 milligrams right here. Okay. Okay. Any comments about combination therapies or medication? That's it. That is. You don't have to memorize like that. You know, metformin has combinations of X, Y, Z medications. It's just a way for patients to reduce their pill burden and hopefully simplify meds. There was a question where you had to just do some math about like, if the person's on this much metformin and this much sitagliptin, how do you convert that into a combo pill? But there's no special thing you have to memorize for combination therapies. It's just a way to reduce the pill burden and make it easier for patients to take. Yeah. Does that answer your question, SJS Scott? Okay, perfect. Okay, now where am I? I am here. Okay, with respect to starting NPH for prednisone, do you need to know if there's any specific guidelines on how of 5 or 10 averages? Oh, okay. So no, there's no special guidelines on prednisone and NPH. It's all just people have tried this and it works. Generally, like I've heard one person say that you use one unit of NPH per 1 milligram of prednisone. And but I find that is too much of a generalization. Like if someone's on some pulse therapy for 50 milligrams of prednisone, I'm not going to put them on 15 units of NPH. That'd be like way too much. So generally, I would, if they're having hyperglycemia for prednisone, I would test how their breakfast and their supper sugars are, see how much of a jump there is, and then I would start probably still low because usually these patients, don't have diabetes. Probably like 5 units or something like that, and then I would just try increasing it slowly to try to get that spike from breakfast to lunch down. But there's no solid rule. You won't find anything in the guidelines that say you must use this or anything like that. It's just a clinical practice thing that some people have found. Yeah, I hope that answers your question, Casey. How long after discontinue? Probably really quickly. As soon as the prednisone's out of their body, usually their sugars come back quite quickly. So I think in the past, I've discontinued the insulin on the same day they've discontinued prednisone. I'm pretty sure that's what I've done. Okay, sure. Thanks for coming, SJS Scott. Thank you for dropping in. Okay, how would you calculate that into a combo pill? So let's say someone's on Jardiance 10 and metformin 2 of the 500 milligrams twice a day. So into a combo pill, that'd be 1,000 milligrams of metformin and 5 milligrams of, usually the combo pills are taken twice daily, except for Janumet XR, or well, any XR version is just taken once daily. But basically, so you take all the metformin, divide it into 2, so it's 1,000 milligrams. And then the Jardiance is usually taken once a day, but now it's being split into 2, so it's 5 and 5 of each. So it'd be 1,000/5 for the combo pill. Does that make sense, Gloriana? Yes, assuming that it's being dosed twice a day, because things like Janumet XR are dosed once a day. Basically, you just have to make sure that there's a pill version of it, because there's no 2,000 milligram pill of any medication. So let me see if this chapter actually shows you. No, it doesn't, of course. Okay, let me show you something that might be helpful then. Okay, so I'm sure each province has their own DBL, searchable drug benefit list, but here you can see all the different combinations it comes with. So you don't need to memorize these for the exam, but basically you just have to be able to fit whatever they're taking into one of these increments. Wonderful. Okay. Test when you use a dorsal great toe is assessment neuropathy. Yes, I would say so. I believe here is somewhere that says like if you've got any lack of sensation on the plantar aspect, that you're at higher risk for ulcers. And yeah, usually though, like on foot care exams, you would examine all of those points. Like here's another great resource, and this is great for real life practice as well. How would you spit long-acting basal? I'll get to that in just a sec, Lorraine. Okay, so the Alberta Health Services partnered with these SCNs and these SCNs, strategic clinical networks. And they made this awesome pathway that I use. And so there's a couple of things. There's this, the foot care screening tool. No, the foot care screening tool. So you can test their sensations in different spots. This is a very thorough one. It's based on something out of New Brunswick, actually. So we copied them. And what's great is that it actually comes with this, a handbook that shows you how to use a tool. And it explains why it was low, moderate, high, explains how to use the pathway, explains like, okay, fissures, you're looking for this, fungus, you're looking for this, etc., looking for black eschar, stuff like that. Yeah, ulcers, stuff like that. Yeah, it explains each and everything that you're testing for. So I find this is a great tool, and I would highly recommend it for people to use in real life. Yeah, even has this thing on footwear and stuff like that. So yeah, that's just under, if you type in, nope. If you type in, it's under just diabetes foot care pathway from Alberta Health Services. Okay, I've got a whole bunch of questions here. Okay, perfect. Okay, so today's not your last day. Actually, where am I? No, you can access it tomorrow, but it's less useful to you once you've written the exam. How would you split long-acting basal? I've never had to do, well, no, I have done that before. Basically, I'll just do it 1 for 1. Like if someone's dose is getting up there, like say they need like 100 units and they're taking 50-50 and they're going low in the middle of the night, but they're high at dinner, I've split it just 50-50. No, like it depends on the situation. Like if usually I split 50-50, 1 to 1, no dose adjustments or anything like that. But let's say they're going low at night, but the sugars are, it depends on the situation. There's too many scenarios, but generally I split 50-50, 1 to 1, no dose adjustments. 11A and 11B, yes, there is some great appendices at 11A and 11B that are right here, as Casey mentioned, that go over the foot stuff very nicely. Okay, for monofilm testing guidelines today, free tests. Yeah, so go with the guidelines, but in real life, I would just go with whatever your local health authority says so. Okay. Any other questions? Okay. Well, well. Okay. In general, it's assuming it's once daily. Okay, if it's twice daily to once daily, usually you reduce it by 20%. Otherwise, it's usually 1 to 1. I believe Atlantis, they want you to reduce it by 20% as well. Actually, no, I've been answering questions all day. Now I'm getting confused. I believe that's it. Let me take a look. Actually, I think I do Lantis 1 to 1 as well. Traceva is supposed to be more potent, but I haven't found it that much more potent. Yeah, 1 to 1. Yeah. So, but if you're going from twice daily to once daily, then decrease by 20%. I believe there is a part here where it says something about other insulins. Yeah, I think it's just 1-to-1. Yeah, for twice daily. Yeah, so if from twice daily, it's reduced by 20%. Yeah. That is funny. Make sure that doesn't happen on your real exam. I guess it's multiple choice, but that would be hilarious. Um, oh, interesting. There's a special one for type 1 diabetes that I haven't read much about, that I didn't read about. Interesting. Okay, here's something interesting. Or I don't know if it's twice daily for all of the way they word this, it seems like it's twice daily for all of them, but maybe it's just once daily for these ones. Insulin glargine 2-gel. I find I need to use quite a bit of a higher dose using it than other insulins. So if I've got like someone on like who needs like 100 on 2-gel, they need like 120, and that's super discouraging for patients. So it's nice for like reducing loads and stuff like that, but I don't often use it because you have to use a higher dose. Yeah, going from 2-gel to Tresiba, I would reduce the dose by 20% just in case. But for the exam, I don't think they would get into that amount of nitty gritty. Okay. Yeah, so if anybody else has any questions, feel free to unmute or just type in the chat. Otherwise, I'm just going to work on these questions here. Probably till just about 5:30. I've been kind of answering questions all day, so kind of getting a little tired, to be honest. But yeah, I might, if I'm able to, I'll try to take a look before I go to sleep, maybe answer a couple quick ones. But I'm probably going to stop mostly after 5:30. Thank you, Jackie. I hope you've enjoyed it. And if you guys need to go, feel free to leave. Don't have me on. Watch me type just for yeah. I do want to say that I wish you all best of luck for tomorrow. Just stay calm, and I think you'll do fine. Just remember those two things about watching the time and not changing your previous answers too much. Yeah, I wish you all best of luck for tomorrow. Please share if you have carb counting foods. So for carb counting, I would just memorize this. And like, Ritu, are you talking about like carb counting as in like calculating an insulin to carb ratio?
No, I was just basically asking about this sheet only. I actually have downloaded, but I don't know, somewhere in all it just went away, and I recall this when you recently opened this one. So I was asking about this, plus a detailed you had written somewhere, like you should know about how much beef and how much other things contain, so that if it comes in the exam for calculating, for example, like 5 slices of bread, or how many berries or how many grapes, so that it becomes easier to calculate.
Yeah, so I'd try to remember as much of this as possible.
Mm-hmm.
And then sometimes they have these like weird oddball items on the exam, like popsicles or ginger snaps or stuff like that, stuff that I would never know in real life.
Right, right. So I was just reading on the ginger snap. So
Yeah,
do you have some more detail of that, or this is the one?
I do. So if you look here, if you just Google Beyond the Basics, this one will show up. This is an older version, which is so that this version is the one you should study from, okay? But
Mm-hmm.
on this one here, it has those weird things like ginger snaps and stuff like that. So yeah, I just ginger snaps, popsicles, I would memorize that. And then I try to memorize as much as way as possible.
Okay.
Okay,
Yeah, yeah. Thanks so much.
no problem. Oh, I got some questions. So just to clarify, correct. Uh, yes, like we had a discussion on this in the exam forum. Oh, I need to check the exam forum. But generally, we think for the exam, I think in the exam and for real life, I've always switched them 1-to-1. Some people, when they're going from Toujeo back to Lantus, have reduced the dose by 20% because Toujeo is actually not that potent. That's the problem. It's concentrated, but it's not that potent. What happens is that what they've done is they wound Lantus into this ball, and then the ball slowly dissolves. But the problem with that is that sometimes this insulin at the center of the ball, it degrades and becomes useless. So you have to use kind of like a higher dose. I would say I don't think the exam will ask that. In real life, you can, from Lantus to Toujeo, it's definitely 1-to-1, but from Toujeo to Lantus, you can do 1-to-1, some people reduce it by 20%. How many grapes for 15 grams of CHO? I believe it's 15, right here, 15. Right here, Lorraine. Are we expecting no specific mental health medications that are linked to her? I don't think you will need to do that. I don't think you need to know like the specific names, like, but you may need to know that antipsychotics can sometimes increase blood sugars. Some antidepressants can increase, just like in general, like, because interesting enough, I actually used to work on the psychiatry ward. I used to work in psychiatry at the Peter Lloyd Hospital. And some people, when they were put on some of these antipsychotics, they'd gain they were like maybe admitted for like 2 months, but they gained like 20-30 pounds on this stuff. So it was really, really significant. The worst ones are clozapine and that O one, what's it called? Something or another. Olanzapine, yes, thank you. Good. Yeah, olanzapine, like I had this patient, she was admitted for new onset schizophrenia. Just like a thin young girl, but in a 2-month admission to stabilize her on olanzapine, she gained like 20-30 pounds. It was crazy. So I think you need to know that some of those medications can do that, but you don't need to know that amitriptyline increases 5 pounds and olanzapine increases 30 pounds or things like that. Let me see what they mention in the chapter, mental health. I don't even think they even mentioned that stuff in the mental health chapter. Here we go. Yes, so if you look at the risk factors over here, where is it? Is this reducing risk or? Here we go. If you look here, atypical antipsychotics right here. Olanzapine and clozapine are atypical antipsychotics. So, well, just from the weight gain itself, like that girl when I was working at PLC, just gaining the 30 pounds was predispose you towards diabetes. So that's correct, Jen. Okay. Yeah, so if you have any questions, just put it into the chat. I'm just going to give myself some more tea, so I'll be back in 5 minutes. Okay, I'm back. Bum, bum, bum. Oh, thank you very much, Casey. Oh, okay. Okay. So one last question about insulins. When starting insulin, I noted we should start 10 units when in the appendix. Okay, so that kind of depends on the weight of the person, Gloriana. Usually I do use just 10 units daily, but for, like, let's say you have this frail old lady who's 40 kilograms, and that actually, and you don't have to, all of those are just guidelines. Like there's another one that's 0.1 to 0.2 units per kilogram. And so in those cases, I would actually just use in the frail older lady, I'd probably just use the 0.1 to 0.2, which would be like 0.4 to 0.8. Because if she's old and frail and very light, then I don't want her to go, she's at high risk of low. So in that case, I would use a lower amount. And then there's the opposite spectrum. Like say you have a guy who's like 400, 500 pounds. Starting them on 10 units will probably not make a difference to their sugars at all. They probably won't see any difference till maybe like 50 or 100. So if you started at 10 and went up 1 per day, they would take them like 2 months before they saw anything with their sugars. And that's super discouraging. So you kind of have to use your clinical judgment and say and kind of see how high their sugars are, if they're frail, if they're how insulin resistant you think they are, and you kind of use that. But for most people, I would say like about 80, like it's kind of like a bell curve, I guess. Like for 80% of the people, I would use 10 units, and then these outliers here, I would use 0.1 to 0.2 or 0.3 to 0.5. Does that answer your question, Gloriana? Okay. So I noticed we had a couple of new participants. This is just meant to be a casual session. Feel free to just type in your questions in the chat or unmute yourself. Otherwise, I'm just working on answering some questions here. So yeah, feel free to just ask your questions whenever. Yeah, exactly. Like if you've got like some 500-pound guy and you start him on 10 and it takes till 100 before he sees anything, like that's super discouraging for the guy. Oh, thank you, Gloriana. Thanks for asking all these questions. I'm treating decreasing. So I don't know. I don't think they would ask that question on the exam, and yeah, you page the emergency doctor for that kind of stuff. You have to correct the potassium. Yeah, because you can use insulin to treat hyperkalemia, so you want to correct before you give insulin, but you could look at the guidelines, and I would just follow that chart, but it's not going to show up on the exam, and in real life, I would page the emergency doctor for that kind of stuff. Where is that? Oh. Yeah, and you'd probably just do it. Yeah, you just. And this is one of those cases I think you would use actually IV insulin instead of subcutaneous. But again, I would page the emergency doctor about that kind of stuff. Yeah, intravenous, yeah. So usually you use subcutaneous in the hospital, but yeah, just one of those instances where you actually use intravenous insulin. No, like to be honest, I know I mentioned that method on that cheat sheet because some people apparently it is a method that some people use, but I've never used it myself. And here, how do I get this? Why isn't it showing up? And I don't think that'll come up on the exam because it's not used much anymore. I think the concept behind it is that as you increase in weight, your insulin resistance goes up. But where is it? Right here, yeah. But no, I don't memorize this chart, and I don't think you need to memorize it for the exam either. Does that answer your question, Jay? Perfect. Oh yeah, those are good. Okay, got some questions here. In the FIT guidelines, it says that rapid acting and long acting analytes can be injected any sites. Pre-mix should be injected into abdomen. For the exam, should we assume that abdomen is the, yes. The abdomen is the fastest and usually the best site for insulin injection. Actually, for all sorts of injections, even like the GLPs, like the Ozempics and Victozas, they suggest going into the abdomen as well. So it's a, I think you can just think of it as the best place for everything. Will there be a lot about pantry? No, usually sometimes there's one question. I think on my last exam, there was no questions on pancreatic transplant. So that'd be a chapter I'd just read once and then just be done with it. You've got lots of other stuff to memorize. If there's like chapters to memorize, it'd be like the nutrition chapter and the medication chapters. Those would be the ones that I would focus on. Yeah, just know the benefits and risks. Like, I believe my question was on how long the pancreatic transplant lasted for, but you know, I don't think I'm not gonna memorize that chapter for one question that may or may not show up on exam. Like, I don't have that much memory to begin with already, so I have to, like, you know, be strategic about it. Oh wow, it's like 5:18 already. No problem. Oh, that is right. Yes. Okay, is Marley here still here? You are totally right. Thank you for looking that up, Lorraine. Okay. Here, let me just add that. Yeah, because the way I thought about it, like these other ones like anhidrosis and hypotension and gastroparesis are things like you don't think of, but lack of sensation is something that you sense. But thanks for that. That's a much better answer than mine. Actually, I'll just put this in. do we count onset and pick at which mix is? Sorry, Jay, I don't completely understand your question. Like there's like in those mixed insulins, they have like kind of like 2 onsets and 2 durations of actions because there's actually 2 different insulins in there. Is that what you're asking? Yeah, so remember that Novo Mix is, yeah, they are confusing. Like a lot of people ask questions on those mixed insulins, but basically, just think of the mixes as 2 different types of insulin mixed in together. And so if you look at Novolin 3070, that's just like Humulin N and Humulin R mixed together. Whereas Novomix is kind of like Novorapid and kind of like NPH mixed together. And so it's just to save the person from having to do 2 injections. I rarely use mixed insulins in real life practice. I think they're quite restrictive, and I don't like how I can't adjust the ratios and stuff like that. Often they're used in places like seniors' homes and stuff like that because it's less, instead of, if you can get less injections, that is always nice. And people in nursing homes generally have a very stable schedule because that's another thing you need with mixed insulins. You need your schedule to be kind of like exactly the same all the time. Yeah, I hope that answers your question, Jay? Perfect. I should do it this way. You guys have actually asked a lot of good questions this year. There's a lot here. Okay. I'll be here for another 6 minutes or so. If you have any last minute questions or any concepts you want to ask me, now's the time to do it. Thank you, Lorraine. Yeah, don't feel pressure to stay here till 5:30. I want to wish you all best of luck on the exam. Just stay calm for tomorrow. Remember those 2 things. Watch your time and try not to change your answers too much. Try not to change your answers too much. Just go with your gut reaction. But best of luck with the exam tomorrow. I hear the format is a little bit clunky, but hopefully that won't be too bad. And yeah, best of luck. Thanks for the kind words. Okay, maybe I'll just deck out a little bit early then. Okay, best of luck, everyone. Just stay calm.